Sorry that we started a little bit late, but yesterday the local organizers, Professor Gynocare and his team, organized a very fantastic social program. So I'm sorry for those of you who couldn't join us, but I highly recommend it to have Professor Gynocare and his team as hosts. So thank you very much. And now we can start off with the first lecture of the day. So it's my pleasure to introduce Professor Alexander Celebic from the Institute of Oncology, Clinical Center of Montenegro, Montenegro. So the floor is yours. Thank you very much.
Thank you very much, Professor Agius. And many thanks to Professor Tofoski and his team for organizing this event and for inviting me with Professor Agius, and it is my pleasure to be here. Good morning once again. My name is Alexander Celebic, so I'm from Clinical Center of Montenegro, and I will try to give some landscapes of neuroendocrine neoplasms as very rare tumors and rare localizations, particularly in gynecology. So, neuroendocrine neoplasms are a rare group of heterogeneous tumors arising from neuroendocrine cells. Neuroendocrine tumors are not so common solid tumor types, and their incidence is estimated up to 5 to 100,000 people. So the most common localizations are gastrointestinal tract, up to 70%, tracheobronchial system, up to 25%, and the remaining, of course, they can be found everywhere in the body, even in the skin, in urogenital system, in CNS, but up to remaining 15% are all others, and among the lowest incidence are those which are the topic of our meeting and of our cross-section, and this is gynecological organs and breast, as Professor Agius told us yesterday, and we had in Malta one consensus meeting during the management committee where we have incorporated the breast also. So, primary gynecological neuroendocrine neoplasm constitute up to 2% of all female reproductive tumors. A distribution among origin of these neoplasms is 55% in the cervix, 24% in uterine corpus, 16% of ovary fallopian tube, 5% in the vagina, and 1% of the vulva. Along the gynecological tract, the ovary is the most common site for low-grade neuroendocrine tumors. In contrast, the cervix is the most common site for aggressive and poorly differentiated neuroendocrine carcinoma. The presenting symptoms are non-specific, but they are organ-specific, and extrauterine spread is very frequent, so 83.6% of uterine, 83.5% of ovarian, and 67% of cervical neuroendocrine neoplasms upon diagnosis. Very frequently, patients, besides the organ-specific symptoms, might develop paraneoplastic syndromes due to the secretion of peptides from these neoplasms, and of course, the neuroendocrine tumors are uncommon and aggressive with high recurrence rate and dismal prognosis, and which makes the treatment approach very, very delicate and challenging. In terms of imaging, the imaging evaluation is similar to other histological types of neoplasms, with added benefits of functional somatostatin receptor, SSTR imaging. And there are no reliable guidelines, this is one of the specificity, no reliable guidelines for either diagnosis or management of these cases in spite of the efforts. And this is just because we are talking about very small numbers, and of course the randomized clinical trials are very difficult to be designed and organized. And the revised FIGO staging system remains the most preferable staging system for gynecological neuroendocrine tumors. This presentation is aimed to focus on a landscape of updated information on NETs in gynecological tract and breast, including but not limited to a staging, classification, clinical pathological features, imaging, and management of these tumors. Prior to go to each of them, very shortly overview, I will give some important, I think, information on nomenclature, because it has been changed from one to another WHO classification in the recent years. So first of all, we have here that grades 1 and grades 2 gynecological tract neuroendocrine neoplasm represents well-differentiated low-grade neuroendocrine tumors. And this is the difference comparing to neuroendocrine carcinomas, which are a grade 3 tumors. So no further differentiations of grade 1 versus grade 2 net tumors in the ovaries. So in ovaries, we only have carcinoid, which is grade 1, and neuroendocrine carcinoma, which is a grade 3. And except for the ovaries, the terms carcinoid and atypical carcinoid were removed from the nomenclature. Instead, these correspond to NETs in the updated classification. Here we do have a table representing the grading criteria. The grading of tumor is based on the Ki-67 index, mitotic index, and tumor characteristics such as necrosis. So we do have one extensive panel of different terminology. So NET grade 1, grade 2, grade 3, small and large cell, and of course we do have small and large cell neuroendocrine carcinoma, and of course we do have mixed types, non-neuroendocrine and neuroendocrine tumors, so they can be well or poorly differentiated according to this grading criteria. In terms of histology, immunohistochemistry is essential to confirm the diagnosis. Of course, here we do have a panel and a landscape of different biomarkers in neuroendocrine tumors. Between them, we do have synaptophysin, chromogranin A, NSC, synaptic vesicle protein 2, and others, but no biomarker is highly accurate. This is very important to underline. So the combination of imaging and circulating biomarkers are a backbone of a good management in terms of diagnosis and in terms of providing additional information on tumor behavior and biology. However, the linear correlation between the imaging, biomarker, and final tissue-derived data have not been established so far, so this making this story even more challenging. Here we do have also another type of presentation of overview of different biomarkers. It is to be underlined that multi-analyte biomarker by consensus has shown that, for example, mRNA have the highest sensitivity and specificity in identifying the minimal disease, predicting the efficacy of the treatment and prognosis. Now we go to each types very shortly, of course, due to time, and features of gynecological and breast neuroendocrine carcinoma. So we will try with cervical cancer. It is the most common site for neuroendocrine tumors in gynecological tract, and it represents up to 1.5% of all cervical neoplasms. They can be classified into cervical neuroendocrine tumors and high-grade carcinoma. So cervical neuroendocrine tumors may be low-grade, grade 1, which include typical carcinoids, intermediate, grade 2, including atypical carcinoid variant, and finally high-grade neuroendocrine carcinoma includes small and large cell neuroendocrine carcinoma. The small cell variant is the most common, then followed by large cell neuroendocrine carcinoma and differentiated grade 1, grade 2 cervical NETs. Only a few cases have been, let's say, elaborated in the literature in terms of lower grade cervical NETs. And of course, it is very important to say that it might exist the coexistence between different subtypes and different types, so adenocarcinoma or squamous cell carcinoma mixed component with neuroendocrine factor. The incidence of cervical NAN peaks around the fourth decade of life. Patients might present organ-specific symptoms, and given the aggressive nature of the neoplasm and extensive lymphatic invasion, distant metastases can be expected at the initial presentation. For example, stage 1B1 cervical, just for illustration, is associated with positive pelvic lymph node in 40% of cases compared to only 10 to 15% with the same stage 1B1 cervical squamous cell carcinoma. Also, it is very important to underline that there is a direct correlation between HPV infection and cervical neuroendocrine carcinomas in the literature. So it is considering, of course, the importance of prophylactic HPV vaccine, and it is very high correlation, up to 88% for large cell cervical neuroendocrine carcinoma. At the molecular biology scope, cervical carcinomas are associated, neuroendocrine carcinoma are associated with mutations in PIK3CA, KRAS gene, and TP53, which makes more, let's say, promising area in terms of investigational drugs and enrollment to eventual clinical trials. Here we do have a FIGO classification. I will not enter into details, but just to underline the prognostic factors for neuroendocrine cervical cancers: FIGO stage, pelvic lymph node metastasis, parametrial invasion, tumor size, lymphovascular space involvement, histological heterogeneity, older age, and smoking. And between all of them, pelvic lymph node metastasis is correlating with as a defavorable factor for disease-free survival, and lymphovascular space involvement, if present, to defavorable factor for disease-free survival and overall survival. In terms of imaging, there is more or less the same as for classical cervical carcinoma, so CT scan, MRI, and including PET-CT with radio pharmaceuticals 18-FDG. In terms of management of cervical neuroendocrine tumors, the treatment is derived from the trial designs of small cell carcinoma of the lung, as the clinical trials are lacking, as all of us know. Unlike cervical, squamous cellular, and adenocarcinoma, which are relatively curable even at advanced stages, the particularity of neuroendocrine tumors are that they are highly aggressive with poor outcomes even when detected in very early stages. So this is very important to underline for this cohort, for these localizations. Multimodality treatment and approach is always favorized, including surgery, platinum-based chemotherapy, and radiotherapy. Of course, we do have here a stage-based treatment algorithm, which is very important to follow up. And from a perspective view, let's say that neuroendocrine carcinomas are unlikely to be responsive to PD-L1 inhibitors due to negative PD-L1 expression, but in contrast, we do have expression of PARP1 protein, so it's giving some hope to be included in the management plan. We switch now to ovarian very shortly. It is up to 1 to 2% of all ovarian tumors are attributed to ovarian neuroendocrine tumors. As I stated before, there is a slight change, not slight, but even a little bit more important changes in the classification from 2014 to WHO 2020 classification. So we do have more simply, and I hope more wise approach in terms of grade 1 carcinoid and grade 3 ovarian neuroendocrine carcinoma. Fortunately, the most ovarian neuroendocrine neoplasm are benign carcinoid tumors with very good prognosis, and a 5-year overall survival is significant, up to 94%. Of course, management is given here. We do have diagnostic and treatment algorithms for ovarian cancer. Of course, if well differentiated and positive somatostatin receptor imaging, then we can treat eventually with somatostatin analogs. Otherwise, we will be approaching with the surgery, with the chemotherapy based on etoposide and platinum-based regimens, and of course, to radiotherapy. If there is a non-surgical or metastatic disease initially, on initial presentation, palliative chemotherapy is indicated or enrollment to a clinical trials. Just to say that prognostic factors are age, AJCC stage, mode of treatment, and histological types. And I can say that overall survival is 73% and cancer-specific 70%. We switch now to endometrial, once again very rare, up to 1% of all endometrial malignancies, 56% of patients presented with advanced disease. What is the specificity for endometrial neuroendocrine neoplasm is that they need to demonstrate at least 2 different biomarkers, such as NSC, synaptophysin, or chromogranin, or CD56, while endometrioid or undifferentiated carcinomas exhibit focal positivity for neuroendocrine marker. But of course, in order to diagnose neuroendocrine carcinoma, more than 20% of the tumor cells need to be positive for at least 2 of these markers. This is very highly aggressive endometrial tumor, and of course, if there is a highly aggressive at the initial presentation, of course, neuroendocrine histology must be suspected. Here we do have the treatment algorithm. Once again, if there is a non-surgical or metastatic disease, we go with palliative chemotherapy, and endometrial tumors are very aggressive, as I said, with 22 months of overall survival in early stages and only 12 months for advanced stages. Now, very shortly, to vaginal and vulvar neuroendocrine tumors, extremely rare malignancies. Once again, approximately 85% of patients, unfortunately, die within 1 year of diagnosis. This is one of the biggest unmet needs. Fortunately, if I can say like this, it is very rare, but for those who has it, it is, let's say, a very frequent tumor. And of course, the specificity is that it is very, very similar to Merkel cell carcinoma, and, but it differs by immunohistochemistry, and specificity is that it can be very mixed with other histological types, most commonly squamous carcinoma and vulvar intraepithelial neoplasia. So, once again, it is for early stages, treatment approach is surgery followed by chemotherapy and radiation, and for advanced stages, there is chemoradiation, which is favorized. Now, from this, we just switch a couple of sentences of breast neuroendocrine tumors. There are the tumors which includes also rare tumors, 2 to 5% of all invasive breast carcinomas. According to WHO classification from 2019, it was underlined that breast neoplasm with predominant neuroendocrine differentiation were classified as neuroendocrine neoplasm, while those with less neuroendocrine differentiation were labeled based on non-neuroendocrine component. So everything is clear when we see this table. So it is a clear neuroendocrine tumor if there is more than 90% of differentiation in favor of neuroendocrine components, mixed between 10 and 90, and less than 10, it is invasive carcinoma, which is preferred classification. They derives from anecdotal case reports of small retrospective series when we are talking about the actual knowledge, and their definition, prevalence, and prognosis remain controversial in literature just because of the lack of evidence. Surgery is the backbone of the treatment for early neuroendocrine carcinomas of the breast. There are no robust data on role of adjuvant or neoadjuvant therapy, and neither in metastatic setting. As for the most common types of breast cancer, treatment strategy should be based on the tumor burden and biological features as the age, menopausal status, general condition, and preferences of the patients. And now we will just talk a little bit about the future perspective. First, to underline the importance of novel targeted therapies, which could play a vital role in treating gynecological tumors, immunotherapy and targeted agents, as well as for other high-grade neuroendocrine tumors. PD-1, PD-L1 have been reported favorable outcomes, efficacy outcomes in other studies for other gynecological malignancies. So it is very challenging how they will behave in scope of gynecological neuroendocrine tumors. And of course, mechanism of action like mTOR, MEK, PTN inhibitors, anti-angiogenic agents might be encouraging and promising, thanking to encouraging results in other non-gynecological tumors. But their part, of course, in treating gynecological tract is limited due to low incidence of or insufficient clinical data, ongoing clinical trials. I know that they exist, but the design is very specific and very rarely it is multicentric. Then it is emphasizing the importance of some frequent mutations like KMT2C and D, which are involved in gene enhancers regulation. Then DDR, like DNA damage response, and CCDC6, which are making them sensitive for PARP inhibitors. And finally, the role of HMG B1 TIM3 and CD47 SIRP alpha are also very promising. Finally, to the conclusions, we can say that gynecological tract neuroendocrine tumors are diverse tumors and often involve and requires, I should say, a multidisciplinary management approach. The small cell neuroendocrine carcinoma of the cervix and carcinoid of the ovary are the frequent gynecological neuroendocrine tumors. The imaging features are non-specific for diagnosis, but it is very important for baseline staging, for treatment response assessment and surveillance. And the adaptive staging system for gynecological tract neuroendocrine tumors is the revised FIGO staging system, which remains valid. There is a lack of consensus on standard treatment guidelines for gynecological tract neuroendocrine tumors. The treatment regimens are usually based on other gynecological and non-gynecological malignancies, as we saw from the presentation. And finally, I should say the importance and underline the importance of clinical trials, the tumor genomic decoding for targeted therapies, accurate pathology grading, tumor basis registries, and a referral to experienced centers of excellence for management of patients in terms of diagnosing and treatment. And last but not the least, networking like this cost action, splendid cost action is. Thank you very much for your attention.
Thank you very much, Dr. Skopje. I think that was a very comprehensive overview of neuroendocrine tumors related to the female reproductive tract. Are there any questions? Okay, I have one small one. So the cervical neuroendocrine tumor, so there is a big correlation with HPV, right? We've actually had an unfortunate case of a non-HPV related neuroendocrine tumor of the cervix. Unfortunately, within diagnosis, she died in a few weeks, not even time for surgery or even for the tumor board to meet. So, in your opinion, I mean, how do you manage? I mean, when you have such a rare tumor, like what? I mean, any thoughts? I mean, of course, the being rare.
Yes, being rare, being specific in terms of management, in terms of diagnostic and treatment, HPV component is important, but more for didactic and academic approach, and particularly for emphasizing and shaping further management in terms of eventual vaccination, because we saw the direct correlation, which is very high. But in terms of cervical neoplasm in general, either HPV connected or not, they are very aggressive. If they are carcinomas, they are very aggressive. They are the most frequent. And let's say if they are presented on the initial stage as metastatic disease, only palliative chemotherapy, which is aimed to prolong the life and to ameliorate the quality of life, but not in fact to cure. So only, let's say, a palliative approach and the best supportive care. Unfortunately, she did not even had that one. So,
in fact, no. But thank you very much, and I strongly encourage you that this wonderful work where you compiled all this information, you might want to consider to publishing it.
Yes, thank you very much for anticipating this, because already during the meeting in Malta, we have been discussing, because I have been always inspirating by rare tumors, and rare tumors in so small countries like Montenegro or Malta are even more rare. So, but we succeeded, for example, for breast tumors, in breast neuroendocrine tumors, to find 5 cases, I tried to sensibilize the audience during the Malta meeting, and I had a positive feedback from Macedonia. And we need at least one more country to be involved with at least one, let's say, case, or to contribute to the, let's say, to the structuring and designing the publication. We need it from the perspective of rules of cost that you elaborated yesterday very clearly. So I encourage everybody who is let's say, interested in this to contribute, and we have published very fastly, because I have a lot of data, and we can, with a very discreet involvement, let's say, of each stakeholders, we can publish this. And not only breast, I encourage also to cover other areas, because maybe they are not so rare if we are all together here.
Exactly. In fact, I already see Dr. Gatta, who is keen. Would you like to add something? Yes. So we have the mic. Yes. Just need the microphone. It's coming.
Thank you. I appreciate a lot your presentation, and I realized that in our list, we take care a lot about the neuroendocrine tumors of lung, digestive, and no thyroid, and skin, but for all the other cancer site, we make just one group.
I see.
And we one group, so we can identify from the Eurocare database the pure organs, breast and gynecological, and we can have a description, an epidemiological description, including incidence and survival. So I think that we can contribute to a very good presentation.
Perfect. Thank you.
I think that the paper is already
Exactly. So,
if you like,
At least the skeleton we do have.
yes, but it's good.
so if you like to publish in the special issue of the European Journal of Surgical Oncology, we are very happy for
Perfect.
Very
Perfect.
good. Very good.
Thank you very much, Gemma.
Thank you very much. Okay, so thank you. So I think we can move on to the next speaker. So I'm very happy to introduce Dr. Milan Paul Kubelak from Romania, so specifically from the Oncology Institute in Romania. So he's going to talk to us about multimodality treatment in ovarian cancer, the present and the future.
So, good morning, everyone. Thank you for this kind invitation. I am very honored in my name and the name of my colleagues to be here and present what we think is the multimodality treatment of ovarian cancer with perspectives to today's standards and what the future holds for us. I will start with a few statistics. They have been probably already mentioned. We know that this is the most the leading cause of gynecologic cancer death. And ovarian cancer, given its incidence, is still considered a rare gynecological neoplasm. And we can see that worldwide, 2 years ago, we had more than 300,000 cases per year, new cases. And the mortality rate was very high, over 200,000 cases. And this is what makes it, by definition, the silent killer of gynecological cancers. We can discuss a bit also about the risk factors. We know that we have the sporadic ovarian cancer, which is multifactorial. In the normal risk population, the lifetime risk is about 1 in 70, with a mean age at diagnosis for the most common subtype at 63 years. The risk factors are given by increasing age, the number of ovulations, so an early menarche, a late menopause, lack of breastfeeding, lack of pregnancy predisposes to a risk of ovarian cancer. And we also can talk about hereditary ovarian cancer, and this is where it's very important, the family history. So for example, if we have someone who has a first-degree relative with ovarian cancer, the risk is much more higher. It's about 1 in 20. And if a person is a carrier of a germline BRCA1 or BRCA2 mutation, its lifetime risk can be up to 60%, which is not negligible. Of course, we also have other genetic syndromes. We have the Lynch syndrome, and we have recently published some data on other genes that are involved in the pathogenesis of ovarian cancer and in the DNA repair machinery, such as BRIP1, RED51, RED51C, D, and PALB2. And what's important to take as a message home is the fact that for carriers of a BRCA1 and BRCA2 mutation, we can offer them prophylactic bilateral salpingo-oophorectomy, which can reduce the risk up to 80% in these carriers. And it's important to have proper genetic counseling for these patients, and all ovarian cancer patients should be tested regarding their own prognostic factors, but also for their families and descendants. Is there a screening program? No. They have tried to do it. There were 2 large trials. We had the UK CTOX trials and the PLCO trial, and none of them succeeded in demonstrating there is a risk, there is a reduction in mortality by using a screening program. And we usually in this malignancy have non-specific symptoms that usually lead to a very advanced disease at diagnosis, but I will come back to this. Its pathogenesis was a debate for a long time, but more than 10 years ago, it was definitely proven that high-grade ovarian cancer originates in the fimbria of the fallopian tubes as precursor lesions. And of course, we have for other subtypes like clear cell carcinoma or endometrioid carcinomas, the presence of endometriosis lesions is the predisposing factor for developing this disease. Now, without making things very complicated, we should state a few things regarding the BRCA genes and the homologous recombination deficiency. So we know that we treat ovarian cancer with platinum, either carboplatin or cisplatin. And these agents, as you can see in the left side, they induce DNA lesions, which can be inter or intrastrand crosslinks. And eventually these, in the middle screen, you can see they eventually lead to double-strand breaks. And this is where things get interesting. We have the DNA machinery that knows how to repair these lesions. And on the right part, we have the HR, the homologous recombination machinery, which is functioning in about 50%, which is properly functioning in about 50% of the cases. And this leads to a total restoration of the initial DNA sequence. However, on the right side of the, on the left side, on the middle image, we have the non-homologous end joining machinery. So these are about 50% of cases that cannot use the homologous recombination machinery. So they are HRD, homologous recombination deficiency. And what this does is just a quick fix of the initial lesion, but it induces mutations that are carried on by the cancer cell, which eventually lead to cell death. And this is important, the fact that cancer cells that have this homologous recombination deficiency, you can see on the pie in the right, about 50% of them are homologous recombination deficient. And this is important because these cancer cells are sensible to PARP inhibitors and to platinum compounds, and these patients do better. This is a short overview of how PARP inhibitors work. They are involved in the initial restoration of a single strand break. We have these inhibitors, these PARP inhibitors, olaparib, niraparib, rucaparib, and so on, that block this initial restoration mechanism, and this leads to double strand breaks. But double strand breaks in a cancer cell that is homologous recombination proficient, these breaks can be repaired. However, in BRCA positive patients and in other mutations that make that cancer cell homologous recombination deficient, which sums up to 50%, these double strand breaks, as I said in the previous slide, cannot be repaired, and these lead to cell death. And this is an overview of the way PARP inhibitors work and have changed the way we treat ovarian cancer. Of course, there are a lot of terms, and we can see that the BRCA mutation is just the tip of the iceberg. Beyond mutations in the BRCA genes, we have BRCAness, which are epigenetic modifications to the BRCA genes that ultimately have the same consequence. Above it, we talk about HRDness, which is a phenotype similar to BRCA mutations, but is induced by other mutations that in genes that work together with BRCA to repair the initial DNA damage. And we also talk about PARPness, other genes that are involved in the reparation induced by poly-ADP ribose. And we can see that all of these sum up, and as I said, BRCA is only the tip of the iceberg. This is the clinical presentation of most cases, and these are some pictures from our clinic. You can see that we have a lot of diffuse tumoral volume at presentation, and most patients are inoperable during their initial diagnosis, and some of the operations we do involve difficult surgeries with the ultimate goal of achieving R0, complete debulking. Some of it, and nowadays, is much more feasible to do after neoadjuvant chemotherapy. As I said, in early stage we have non-specific symptoms. In advanced stage we have abdominal pain, bloating, dyspnea, emesis, constipation, signs that send that patient for an initial physician evaluation. The definitive diagnosis is made on histopathology, and it's important to stage that patient according to the FIGO system. And we have evidence, as shown in the lower right image, that patients do better in if they are treated in large volume cancer centers. So it's a difference between a center that can treat more than 25 cases a year versus a center that can treat only a limited number of patients per year. So the volume of patients you treat every year is prognostic for the patients you have. So an overview of the clinical treatment. We usually after we have diagnosis, we stage those patients, and they can go in two directions. We can either have primary debulking surgery, which is, let's say, for early stage lesions, that is enough. We can offer those patients only surveillance. But for more advanced cases, we also need to offer adjuvant chemotherapy. For cases that are really advanced, we start by doing neoadjuvant chemotherapy with interval cytoreductive surgery. And depending on the outcome, the American guideline also says that we can add intraperitoneal chemotherapy, but that is something I will come back to. And we can also consider in the maintenance phase after the interval debulking surgery offering bevacizumab or PARP inhibitors, which I will also come back to. So the issue of HIPEC is really debated. We have an Italian group that is really keen on doing it. We have the Professor Dubois from Germany, who doesn't believe in the evidence that is presented so far, that is published in the literature. Literature can also have a bias. There are also two trends of thinking regarding HIPEC and intraperitoneal chemotherapy, the American one and the European one. And I will come back to this. So just pointing out to early stage ovarian cancer, for stages 1A, 1B, grade 1 or 2, we do not need to offer on a regular basis the adjuvant treatment, but for cases that are above this, there has been a benefit of adjuvant chemotherapy that brought an improvement in progression-free survival, about 11%, and in overall survival, about 8%. In advanced ovarian cancer, we definitely need to provide adjuvant chemotherapy. We have trials showing that it is beneficial, a combination of platinum and taxanes, as I have already said. We usually deploy 6 cycles every 3 weeks. We had recently published the ICON-8 trial, and it didn't show any benefit of using dose-dense chemotherapy. So we are sticking to the standard 3-week scheduled treatment. Going back to what I said about the US and the European perspective on intraperitoneal chemotherapy, the Europeans are much more conservative, and they say that women should not be subjected to intraperitoneal chemotherapy outside the context of properly designed clinical trials. Of course, we have a paper that has been published in the New England Journal of Medicine, which we can say it's like a Bible. But however, Professor Dubois, when he was analyzing the journal, we can see that regarding selection of patients, there were no clear-cut criteria used for defining patients. It took more than 9 years to complete this trial. There was no qualification criteria for which centers can do this, and there was also no information in the paper about the surgeon's qualification. So there are a lot of things to debate about intraperitoneal chemotherapy. And we can see from the ESMO-ESGO consensus conference that they clearly state this is not the standard of first-line treatment. Either we talk about IP chemotherapy or HIPEC. So going back to advanced ovarian cancer, we usually provide neoadjuvant chemotherapy for patients where complete cytoreduction is unlikely or they are poor surgical candidates. And we have here the evidence of the trial published by Ignaz Vergote back in 2010-2011, which showed basically no difference in survival. But of course, this was a surgical trial that was, again, debated regarding quality of the surgical centers included. So we have a new trial, the TRUST trial, which is the trial on radical upfront surgical therapy, which highly selected centers for doing this either primary debulking surgery or interval debulking surgery, and we are expecting to have results in about 2 years to definitely solve this issue. And this is where I would like to present you some of the results we have done in our institute regarding this issue. So the issue is that in patients with prior chemotherapy, so before chemotherapy, you can clearly identify the intraperitoneal lesions. However, after chemotherapy, it's much more harder to see the residues, the tumoral residues from the peritoneal cavity. So we have proposed the solutions, and so have others that have recently published at ASCO. The solution would be to use a fluorophore, which is conjugated to folic acid, and we know that on ovarian cancer cells we have a lot of folate receptor, and using a near-infrared visualizing technique during intraoperative surgery, we can better identify this remaining tumor foci that we can surgically take out, which basically represent those clusters of cancer cells that have not responded to initial chemotherapy, which are resistant and which will drive the further relapse of these patients. So using an infrared microscope together with colleagues from the chemistry and the physics department, we have devised this project. This is some of the images we have, I would like to present to you. So we have the optical image and also the near-infrared image. And by identifying different foci, this is using just plain ICG, which can evaluate the microvasculature of those lesions. We are also planning to developing a compound that is targeted towards cancer cells, so coupling ICG with folic acid and make it possible to administer to real patients, not only on animal experiments, but this is still ongoing work. And here I have a video, I hope it works, to show you how this looks. This is after we administer the ICG, and you can see we have different white and black areas on the peritoneal surface. So this is only with plain ICG, and this was our preliminary data where we identified this foci, either white or black, and took them out and analyzed them in pathology to see if they contain cancer cells or not. Our hypothesis was that black spots usually means less vasculature, which means fibrosis. That is a consequence of neoadjuvant chemotherapy in an intraperitoneal tumor implant, where we could find remaining cancer cells in a very fibrotic stroma. And this is something we did on mice, where we tried to administer novel compounds to mice to see, as a proof of concept, if this can help us. We found a melanoma. We injected melanoma cancer cells in the mice intraperitoneal cavity, because melanoma cells also have this folate receptor, and it was much more easier to induce carcinomatosis in mice than with ovarian cancer cell lines. And you can see that after injection, we have a hyperintensity also seen in tumor areas when we focus on those areas. So this is what I wanted to show you as part of the future. Some of the data we presented last year at ASCO, we will also present something on this year on ASCO, thanks to the grant provided by this cost action. And going back to advanced ovarian cancer, what do we do after we have this interval debulking surgery? Well, we have maintenance options that we can provide for these patients. We have bevacizumab, which has shown an improvement in progression-free survival, but not in overall survival. We have PARP inhibitors, that is another option for maintenance. And recently, we also have a combination that we can offer that is PARP inhibitors plus bevacizumab. And you can see on the lower right, we have data from 5 years follow-up of patients who received in the SOLO-1 trial, so patients with BRCA mutations who received only olaparib as maintenance. We can see that we have a median progression-free survival of 56 months compared to 13 months. And this is really spectacular, what we have obtained in ovarian cancer treatment as maintenance. And speeding up a bit things, it's also important not only to give PARP inhibitors, but it's also important to have good surgery, because it was shown that good surgery augmentates the effect of PARP inhibitors. And this is an example of, sorry for the animation, of a patient. This is how it initially presented itself with very advanced disease, and this is how it looks after maintenance treatment with no evidence of disease more than in 2 years of follow-up. So there has been a lot of progress in the first-line management of ovarian cancer. We had the first paradigm shift in 2011 when we introduced bevacizumab. We had the second paradigm shift in 2018 when we offered olaparib with the SOLO-1 trial. And another change was in 2019 when we had new combinations for olaparib and bevacizumab and the other treatments with niraparib and veliparib that we can offer even in the absence of a BRCA mutation. So it's enough to have patients who are homologous recombination deficient. So that is up to 50% of them. And regarding our choices during first-line treatment, a first choice is to offer neoadjuvant chemotherapy or primary debulking surgery. A second choice would be to add or not bevacizumab. And a third choice would be to add or not a PARP inhibitor. A few things about recurrent ovarian cancer. Things haven't changed so much. The only thing that really matters is how many months have passed since the end of the first platinum-based chemotherapy. So if a patient has over 6 months of progression-free survival, then we can offer again a doublet of carboplatin paclitaxel. If we have under 6 months, we consider that patient to be platinum resistant, and we usually offer single agent chemotherapy. And it's important to have an overview of how things work. It's important to prolong as much as possible the first progression-free survival, because afterwards we have successive shorter progression-free survivals, which eventually will lead to bowel obstruction and death of patients. And of course, we have a lot of options now, but things were quite simplified in this ASCO presentation from this year. So if we have a patient that initially had a PARP inhibitor, then at relapse, if it's possible, we offer chemotherapy plus bevacizumab. A second option, if we have a patient that received bevacizumab up front, then at relapse, if they are platinum sensitive, we can offer chemotherapy followed by PARP maintenance. But we have an unanswered question. What do we do at relapse when we already offered patients PARP inhibitors and bevacizumab? Of course, there's a question of survivorship. We have a high risk of cancer relapse. And there was also this controversial trial, should we follow these patients closely or should we start treatment only when they have symptoms? And this trial from Gordon Rustin that was published around 2010 said that it was no difference between detecting an early relapse versus when patients had symptoms. But things have changed since then regarding systemic therapy and the question whether of or not these results are still valid requires further discussion. And of course, we need to think about these patients. They have a fear of recurrence, of depression, of paclitaxel-induced neuropathy, of fatigue, and these also need symptom control. And only a few slides about what's happening now. We have new PARP inhibitors that are much more selective and have better results. This is something that has been published in July this year. We have the new AstraZeneca compound AZD5305, which is more tolerable. We have other agents that are in development regarding DNA damage response. We have a lot of phase 1, phase 2 trials targeting different targets, CHEK1, WE, ATR, DNA PK, ATM, other genes and other proteins involved in this DNA repair machinery. We have novel therapies that target either the tumor microenvironment. We have improved drug delivery systems. And here I would like to mention the antibody conjugated proteins. We have ways of trying to tackle this PARP resistance by associating some of the agents I mentioned previously. And we are also trying to enhance the PARP inhibitors activity by combining them with immunotherapy and with anti-angiogenetics, as this has been shown to be more than additive when adding them together. And we see that these antibody drug conjugates have a confirmed objective response rate between 32 and 46%, which is a lot, especially when we consider that the patients that were included in these trials were heavily pre-treated patients. And this being said, I would like to thank you for your attention.
Thank you very much, Professor Kubelak. Are there any questions? Microphone or someone?
Good morning, thank you for your beautiful lecture. I'm a pathologist from University Clinic of Radiotherapy and Oncology, and I want to ask you about the low-grade serous carcinoma of the ovary. I know that surgery is gold standard, but chemotherapy and PARP inhibitors are not so good for therapy of this type of cancer. What about MEK inhibitors, and do you have your personal experience about low-grade serous carcinoma?
They don't respond as well as high grade, and of course this is the reason why surgery is continuing to be the main treatment of this disease. The guidelines also say we can use chemotherapy, but regarding targeted therapy, there's nothing really standard about it. That there have been some reports on it that we can try different targeted treatment that has been proven to work in other malignancies. So, for example, MEK inhibitors, we know they work very well in melanoma patients, but we need to be cautious about this because MEK inhibitors won't work the same way in melanoma cells as in ovarian cancer cells, because even though we might have this activating pathway, we need to take this into context, and the way a melanoma cancer cell works differs from an ovarian cancer cell.
Thank you, Paul, for this presentation. I would like just to ask concerning nanonear study that you have presented, and I understood that it is original contribution of your institution in your team. Have you ever thought maybe of prolonging this or introducing this program into the new innovation grant? Have you discussed maybe with Jean? I think it would be a good idea, along with the presentation of Professor from Czech Republic.
We haven't actually thought of it, but now being said, It could be a possibility. Theoretically, our grant will end, for which we got funding, will end in a couple of months when we have to make the final report on it. So what we tried to do was to develop compounds, so targeted compounds which have this fluorophore we can see, which is attached to folic acid. But the innovation part was to make these compounds last as long as possible in the bloodstream. So not only for 3 minutes you make an injection, the surgeon can see for 3 minutes, because that's insufficient for ovarian cancer. So you need something that would last for half an hour or more. And the aim of this project was to try to develop initial compounds that can do this, try them on animal experiments, see if they are toxic for them, and this was the final deliverable of this project. So maybe it would be something to go forward from here, but we need to discuss it.
Professor Dimitra?
Hello, thank you for your wonderful presentation. And I have a rather charismatic question. Because me and Professor Mandic know well the legend of the treatment of ovarian cancer, the retired Professor Andrea Dubois. He's now retired, I think, 2 or 3 years.
Yes.
And then I would like to know the meaning of the sentence that was not translated. It was either Romanian or Latin.
It was Latin.
Latin, yes.
Yes.
I could catch because we changed the slide very, very fast. It was something in the hands of God, because the ones that are against the high-tech say that you leave the patient in the hands of God or something like that.
Yes, it was something like that. I put the slide. This was a very interesting debate that they had in ESMO Congress in 2018. So Professor Dubois was kind of mocking the group that was doing this, because you need to have something that can be done, which can be feasible, and not hyper-select your patients only to adjust in a way to have positive outcomes in your study. And nowadays things have changed a lot. Of course, this was a matter of hot debate of using HIPEC, but this was before PARP inhibitors, and it was before immunotherapy, before bevacizumab. So now we have other systemic therapies that can change, and this is not a valid question no more. We should have new trials with HIPEC and PARP inhibitors and bevacizumab and immunotherapy to see if in this context this HIPEC offers something or not. But these are very difficult trials to do.
And maybe they should be combined. And what did you feel that the debate was? How many percentage was for and how many against?
In your Professor, most of them agreed that HIPEC should not be considered standard because it's very hard to do. It's only in few centers. You have a lot of toxicity, and the outcomes are debatable.
Any more questions? Thank you very much.
Thank you.
I would like to announce our next lecture. It's Professor Aljoša Mandić.
Okay, good day to all. Also, I would like to thank the organizer to invite me here, and I'm happy that I'm here with among my friends, of course, and to meet another good people and good friends with the different field of interest in gynecology. So, I will talk about some maybe a tricky one. If we want to. And just to say that we'll see what's at the trials and what's at the real life. And among all these things that we have one, maybe it's not a rare tumor. Somewhere it is, according to according to the definitions in Scandinavia, let's say in cervical cancer. But there are some rare group of the young patients. And to get and to know all these things about the cervical cancer and oncological outcomes, do we have some ideas for them, especially in a group of the young patients, nullipair, who desire to get pregnant, to be mothers? Because we know today that it's postponed, the idea about the pregnancy in young women. But unfortunately, it's overlapped with the precancer and cancer lesions in the cervix. So I will try, where is the rationality to use the chemotherapy? Since 2003, one of the greatest gynecologists, Benedetta Panici, Sardi, Palladini, found that interesting that using the NACT, so the cervical cancer is chemo-sensitive. Found that survival is better for 14% and from 50 to 64. And that was the interesting, so if meta-analysis showed that, so why don't continue with that? Unfortunately, if you always dig to the trials, you will find that criticism of these trials shown in one meta-analysis that most of these group of radiate patients was not even in 30% get the brachytherapy. So, and also the radiation in back 19s and nowadays developing also much technology in radiation field improve that. So the trials continue to try to get the neoadjuvant treatment and where is the place of the chemotherapy in the cervical cancer. So we get two pathways for using the NACT. So the first, is it possible to downstage the tumor and then do the radical surgery in this group of the patient? But for me, for the start, if you also dig in all these, I think this is heterogeneous group. So the bulky tumor and the local advanced tumor. And we know through the epidemiology cases and epidemiology studies that the increasing the risk to get the lymph node metastasis in local progressed the cervical cancer. And also for the young patient, fertility sparing, we know all about this fertility sparing in the early cervical cancer. But this contact, neoadjuvant and stage 1B1, just to get the less surgery, is another question. You can find in standard treatment. You will not treat the ordinary 1B1 with the chemotherapy, just go to radical surgery. So these are too many questions. But unfortunately, during the trials and studies, especially ERTC study, the big one study, shown that there is no benefit. The chemoradiation is the cornerstone of this group, comparing NACT followed the radical surgery. This is a Gupta studies in 2017, but also, again, if you dig in that group of the patients, you will find majority patients with 2B. And also the authors mentioned that maybe there is something in the bulky tumors, 1B2, that is according to the last past figure classification. It was not used 1B2, 3, but bulky. I will talk about bulky tumors. Also, one great meta-analysis also shown there was negative if we talk about chemo, if we compare chemoradiation, neoadjuvant followed radical surgery. What said our greatest societies who we are looking and follow these recommendations? So ESMO had some said that study results indicate that NACT, so it's not closed the door for the NACT. ESGO is stronger in this and said it's controversial, it's still experimental, and we have to look about that. But still, it's not closed the door. So right now, if we are not talking about the fertility sparing, I think that these local advance, this definition of local advance of 2A, 2B, there is no place anymore, especially in nowadays modern radiotherapy technologies. But for the bulky tumors, I don't know. But you will see it through the cases, because that is something that's come in your daily practice one day. So just for a small review of the oncological outcomes, because in the fertility sparing we have to look in two ways: oncology outcomes and obstetric outcomes. Why do something in the gray zone if you will get a patient who have a problem with fertility? So that is one of the parameters that you don't use that. So vaginal approach, abdominal approach, it was shown that the early tumors less than 2 centimeters is acceptable recurrent rates comparing the radical surgery. So we can offer that to the young patients. But also, is that so radical? Do we need that so radical surgery? Because we know that small tumors have less risk to get the parametrial infiltration lymph node metastasis. So it was shown that the less radically, so small tumors do the small surgery. It's acceptable recurrent rate. But unfortunately, the diameter of tumors, bulky tumors, it's a bad prognostic factor, whatever. But still, they're doing. And then from the abdominal and vaginal radical tracheolectomy, in that small tumors, there are a group of authors that try to do the small, less surgery, cone, simple tracheolectomy, and they found also acceptable recurrence rate also. So we think about that. The plan showed also the 2000 in Lisbon, the also importance to detecting one of the major cornerstones when you will try to start the thinking about, so it's assessment of the lymph node. But not all pelvic lymph node, just sentinel node. It will show good results. So that was the beginning of the starting one of the greatest, for me, studies that we are waiting, I will show later on. And then, if we have a chemotherapy that shows something in the bulky tumors, but unfortunately the trial said no. We had young patients with bulky tumors, and who desired fertility. Don't forget another problem here. Very young patients, fragile patients. So this is the group of the patient that need the multidisciplinary approach forever, especially psycho-oncological. And then it came an opening. So it was shown about 6% of all these cases, 6% of recurrence. With all these things, we didn't help each other. Just we opened the Pandora box with so many questions. So is the preoperative sentinel node detection the mainstream in these cases? It will show it is. Lanowska is author of that and show go to the lymph nodes, sentinel nodes, whatever, and if you get the positive lymph nodes, then it's for chemoradiation. There is no question about it. What after neoadjuvant? And good response. Do we do the radical surgery, or if we shrink the tumor, if we small the tumors, we have some previous results of the less surgery. Is that the group for the less surgery radicality? We still don't know. The main question is, what about the non-responders? Because they were shown that indirectly for these patients who didn't react on the neoadjuvant, they did not react on chemoradiation also. They are bad responders for chemoradiation also. And what about the protocols? There are no standards. There are lots of different, but also platinum regimen is and paclitaxel standard of care. And now cases. 25-year patient, cervical adenocarcinoma was diagnosed at a routine gynecological exam, confirmed by punch biopsy, Figo stadium. This is the old one, it's 1B3, it's more than 4 centimeters. According to the MRI, suspicion lymph node. standard procedure, what will be? Chemoradiation. But she didn't think about that. She told to me, okay, I go to the balcony and fell off, jump. I don't care. I don't want to do chemoradiation. I don't do nothing. I don't want to lose my womb. Psycho-oncologist talked with her and everyone. She said, give me something more. Give me some. So I have a headache through the nights. What to do with the lady, 25 years old. He will do the suicide because he's for chemoradiation. And then I decided, because I was a fellow of ESGO in Prague with Professor Cibula and Professor Lucas Robb, and they do, there is something. I can't say patient, okay, go home and die. Okay, I'll try something. And I did the Prague protocol, 3 cycles, dose-dense interval, cisplatin, doxorubicin, because it was adenocarcinoma. Not because I don't know how to use the paclitaxel. Unfortunately, in Serbia, it's not registered for cervical cancer. Yeah, unbelievable. But I can get, because the paclitaxel, cisplatin, especially Leuven protocol, dose dense. Why dose dense? Because it was shown through the meta-analysis that short interval in platina is much better. And after the 3 cycle, repeat the imaging, no lymph nodes, shrinking the tumors on cervix, and then through the 2 hospitals, through multidisciplinary approach, did the abdominal trachelectomy in 2013. So find a pathology, tumor diameters less than 2 centimeters. The most important, these deep stromal infiltration, about 40 millimeters lymphovascular positivity, but 40 lymph nodes without metastasis. In follow-up of that lady is free of the disease up to 2022. I'm not a good mathematician, so just see how long is free of the disease. Unfortunately, pregnancy, 0. The Brown, there is one study of the Brown that is another question of that, shown that after these procedures in these young patients, more than 50% don't think about pregnancy anymore. This is the bad. This lady also don't think about that. But another lady with planocellular carcinoma in 2017, it was found locally, but exophytic tumor, planocellular, more than 3 centimeters. On MRI, it will show no deep stromal infiltration, so exophytic, but it's multifocal. We decided to give also the Prague protocol with ifosfamide. I will show you. There is one question about gonadotoxicity in chemotherapy in the young patient, but you will see what I'm thinking about that. So these are the pictures of this lady before first cycle, third cycle. At colposcopy, I didn't find nothing. So I was afraid it's a complete response, so I did a punch biopsy. It was shown the high seal. MRI didn't find nothing also. So we did the laparoscopic pelvic lymphadenectomy because we don't have the material for do the sentinel node, because the sentinel node is the right option for her, not to do even pelvic lymphadenectomy. Conization, and find the high seal endocervical, no tumor lesions, 21 lymph node without metastasis. Follow-up, local control this July, no evidence of the disease, pap smear normal, and 1 pregnancy and born 1 healthy boy called Aljosh. And that is that big reward for everything. She's well. If we look all these table, this is a very interesting table because it will show the old approaches in that early cervical cancer. Simple trachelectomy, Dejean's or vaginal approach, radical, abdominal radical, and see the recurrence rate. It's all there. It's acceptable. So what about the procedure can introduce all, it could be effect on fertility. We show that a little bit increase in neoadjuvant chemotherapy. So we can say maybe it could have gonotoxicity problem. But look at the, where to look at? To pregnancy rate. Over there. The pregnancy rate. It's acceptable, even much better in neoadjuvant chemotherapy. Even much better. So, but according to the law of the big of course societies, ESMA said that for tumors more than 2 centimeters, neck followed by conization or trachelectomy may also be a valid choice. So they didn't close the door. But you have to speak with your patient. You have to approach with multidisciplinary approach. And finally, the review of these cases, thanks to Buddha, who showed in 2022, published very interesting review, where find 140 women with bulky tumors possible candidate for NAC and fertility surgery. It was shown that the patient reached optimal pathological response to 61% of the patient. And also found that suboptimal response to NAC appeared to be an independent negative prognostic factor. So in conclusions, neoadjuvant chemotherapy, prior fertility sparing surgery is an option, according to this review, but it's a small number, of course, of patients, because the literature about this issue is still weak. And fertility sparing should be carefully discussed with the patient. Also, you need the informed consent for that. That patient know what you offer. You don't know what you offer also, because you don't have results of these. And the last thing about the tumor diameters, that is also, it could be one very interesting and one bad prognostic factor. According to the Spanish group, they found that the tumor more than 2 centimeters had a negative prognostic factors. Have to think about that. So neoadjuvant treatment in this bulky tumor is very, very small patient and very contradictory. Where is the place of neoadjuvant? Contessa. Dear Contessa will show us, probably, I hope so, with the PI of the Marie Plan. Are we doing something like in a trust study that colleague told about neoadjuvant and primary debulking surgery? This will be a very interesting trial. For now, in very rare group of the patients, you can offer some algorithm of these patients with the bulky tumors, but assessment of lymph nodes is the crucial. If you get positive lymph nodes, exclusive chemoradiation. Don't do the surgery at all, because the ABRAC study by Prague group shown that there is no effects at all, surgery or chemoradiation. So aborted operation. Professor Dimitrov had a lecture in Novi Sad about that. Neoadjuvant triple or this Leuven dose-dense protocol, it's very interesting with the paclitaxel and cisplatin. And also, if you have some complete partial response, do the option for the fertility preserving. So what next? Okay, trials need more evidence. That is the main question. That is the main sentence for all of us who are doing something. We need more trials. But the most important for me thing is looking for better responders. How we will find it will be biomarkers, maybe, such as in ovarian cancer, such as in endometrial cancer, also with molecular profiling. We have good and bad responders. Do we have that option in cervical cancer, such as VEGF, PDL, molecular profiling? Is the paclitaxel platinum only option nowadays? Treatment changing in neoadjuvant setting by using the target, immunological, biological treatment? We don't still know. about that. But for the future generation of our colleagues, just to prevent these headaches, go to the powerful prophylactic vaccine and decrease the incidence of cervical cancer. There is a result, and we can do that. Thank you very much, and of course, welcome to our European capital of culture, Novi Sad, Serbia.
Thank you very much. Are there any questions for Professor Mandic?
I have only one proposition. It is not a question. For all of here, maybe Professor Alia Kajus is not here. She's on the press conference, but my proposition is that the site, think about that, that the site of the future Gynocare area gynecology and pregnancy should be Novi Sad, one of the next sites of organization. So if we like to vote for that, so
Yes.
voting for it maybe next year, maybe the year after that.
Welcome. The Serbian Society of Gynecology wish you welcome, of course, in Serbia. Okay.
Thank you very much, Professor. Our next speaker is Professor Angel Yordanov from Bulgaria.
Good morning to everyone. Yesterday and this morning we have very serious presentations, so I will make a more simple presentation, rare vulvar and vaginal tumors, cases from the practice. Why? Because I truly believe that rare tumors are rare only in the statistics, not in the practice. This is what rare tumors means by the statistics. It's repeat a couple of times these days. But what rare tumors really mean in the real life? This means problems. This is the problems for the patients, the problems from the whole medical team, and of course, in the end of the story, the problems are for the patients again, because the patient will pay the price of lack of our knowledge or the price of our knowledge in the end of the treatment process. What we know about the vulvar tumors by the literature. Vulvar cancer is 5% of all malignancies of the female genital tract. Its frequency is 2.5 to 4.4 per 100,000 person per year. Fourth most common gynecological malignancies. Other malignant tumors of the vulva are melanoma, Paget diseases, and the sarcoma. Sarcoma is between 1.5 to 5% of all vulvar neoplasms. When you make a literature review, you will find a little information about all these tumors. Leiomyosarcoma of the vulva is one extremely rare malignancy. It's only 1% of all vulvar malignancies. It's the most common type of vulvar sarcoma, more common in the middle age, and it's located in the most cases it's located to the labia majora, to the Bartolini glands area, clitoridis or labia minora. We present one case from our practice of 73 years old patient, which is with tumor with in size 7 to 5 centimeters, which was present for several years, but in the last 3 months it has doubled in size. Why we present this case? It's not so interesting like a case, but because the patient came to our department with the diagnosis skin infection or soft tissue infection. And this is the picture of, sorry, can you help me?
Presentation.
So this is the picture of the patient. This is the tumor. This is the soft tissue infection. When we make a radical excision, of course, we have a diagnosis of the classical leiomyosarcoma. We present this case because the problem for the patient was that we delayed the treatment with a couple of months because she was treated for the soft tissue infection. Vaginal tumors, this is the statistic you can find in the literature. 3% of melanoma, 3% of sarcoma. It's very difficult or even impossible to make a differentiation between benign and malignant tumor by MRI. Only histological diagnosis is accurate. And we present a primary non-Hodgkin's lymphoma of the vagina, which is a very rare situation for the patients. Only 1/3 of all extranodal of all presentations are extranodal, and the vagina, cervix, and uterus are affected only in 1 cases from 175. So it's a very rare situation, very difficult to be diagnosed, and we present a patient, 71 years old, which came to our department with diagnosis locally advanced vaginal cancer. Why? Because we have this picture. This is not very good picture because it's happened in the beginning of my career, so I didn't know how to make a presentation and how to make pictures of such cases. But in the vagina we have a couple of nodules which were very easy bleeding when we touch them. So the patient and here the interesting part of this case is that when we have the diagnosis, primary non-Hodgkin lymphoma, we make a whole body CT scan. We show that there is no other localization of this disease, and from here we start with the problems. 3 months we lost with the beginning of the treatment because no one from the Department of Hematology believed that this is possible. We make 2 new whole body CT scans. We have 2 revision of the histological materials. Even in the Germany they were sent to show the diagnosis. The other part of vaginal tumors are smooth muscle tumors of the vagina, and of course these tumors are leiomyosarcoma and the myoma. The problem between these 2 tumors are that they have the same presentation, and there is almost no possibility to be diagnosed by MRI or CT scan. Leiomyoma of the vagina is a very rare disease. Only between 300 and 400 patients are reported in the literature, and we present 1 case of 45 years old woman with solid mass in the vagina, 5 to 5 centimeters. Why we present this case? Because 3 months earlier the patient has supravaginal hysterectomy, and when we enucleated, when we resected this formation and sent to the pathologist, we have a call which was from the colleagues who said if this tumor is found new, this is de novo developed tumor, this is a low-grade sarcoma. If this is an old tumor, this is a usual myoma. Tell me, how can we explain this to the patient? You have probably benign, and most probably this is benign tumor, but there is a possibility to be a malignant one. This is a very difficult situation for the doctor who is involved with the treatment of the patient. So we have luck, and after 7 years the patient is without data for recurrence, so obviously this is a usual benign tumor. But the next patient is with leiomyosarcoma. There is only 140 reported cases in the literature. The symptoms of the leiomyosarcoma is absolutely the same as the symptoms with the patient with the myoma. There is dyspareunia, vaginal bleeding, lower abdominal pain. So the patient is 35 years old. The medical information is not so interesting. This is the picture of the myoma. As you see, there is a uterus with intrauterine device in it, and you see the wall formation, which is more than twice bigger than the uterus. So there is problems with these patients about not about the diagnosis itself, but what surgery we can perform here. We make a hysterectomy with inoculation of the tumor for the vagina. There was a histological exam which showed the diagnosis leiomyosarcoma, but the problem starts from this moment, what to do next. The tumor board was not, how can I say, we have no one opinion what we can do next. Some of the colleagues want to make radiation. Some of the colleagues think that the patient has to be only left on observation. The patient, in the end of this process, the patient decided for herself that she didn't want any kind of treatment. So 8 years after that, she is still alive without date of recurrence. Another vaginal tumors, a vaginal metastasis, they are more often metastasis from the other gynecological organs, cervix, endometrium, or ovaries, and of course from the gastrointestinal sites, colon, kidney, breast, and even the pancreas. But we present one very strange metastasis by renal cell carcinoma, a 60-year-old patient, which was, this is the look of the metastasis. The patient came to our department because of excessive bleedings. What was the reason of this bleeding? The patient goes to the obstetrician, to the gynecologist, because of this formation which is shown from the vagina, and when she was examined, the bleeding is starting. She came with hemoglobin 60. So here, in this case, we have no surprises in our clinic because we have similar cases 10 years ago. So we are sure that this is the metastasis from the renal carcinoma. We make excision of the carcinoma because it's necessary to stop the bleeding, and when we make a CT scan, we found the tumor in the left renal vein and in the kidney. We found some nodules in the thorax. So we send the patient to the department of chemotherapy, and after 1 year of treatment, she came back to us with the metastasis on absolutely the same place. And in the end, I want to show you something which is not a malignant tumor, and want to say that not every formation in the vagina is from the vagina. We have a 36-year-old patient who came to our clinic with this formation, more than 15 centimeters, necrotic one, and she was sent to us with a diagnosis of very advanced vaginal or cervical cancer. There was not one opinion about that. I'm sorry, but I can't find one of the picture. This is the tumor. After a couple of examinations and after a CT scan, we decided that this is a nodulus myomatosus, which is going through the cervical channel, and this is the specimen of after the surgery. So why we present these cases in such serious conference, such sample cases? Because the rare tumors are not so rare, as I say in the beginning. They are rare only in the statistics. And every one of us will meet with such tumors. The statistic means nothing for the ordinary patient. When we have a patient with some rare tumors, it's rare only for us. For the patient, this is the whole word for him. When we say you have some kind of rare tumors, this means nothing to the patient. He don't want to know is the tumor is rare or not so rare. He wants the decision for his problem. That's why me and my team truly believe that every case with such rare diseases has to be reported, because only knowledge which we'll take from these publications can save the life of the everyone patient, the ordinary patient. Thank you for the attention, and I'm sorry, but I'm very excited to be a part of this event. So it's shown by my presentation. Sorry again, but thank you very much to be a part of this event in Macedonia.
Thank you very much. Thank you very much, Dr. Yordanov. Are there any questions?
Thank you again.
I would like to ask you for the coffee break. If you want, we will proceed in 15 minutes.